I now welcome Dr. Kapil Yadav sir to deliver his talk on community participation for reducing anemia. Dr. Kapil Yadav is currently additional professor at Center for Community Medicine, AIIMS, New Delhi. He has completed his MBBS from University College of Medical Sciences, New Delhi, and MD from AIIMS, New Delhi. He has worked at Indian Coalition for Control of IDD, New Delhi. His core areas of interest are anemia and iodine deficiency disorders, micronutrient deficiency, public health nutrition, food fortification, social determinants of health, epidemiology, and community based research.
Thank you, and special thanks to Professor Bhatia, sir. It's a privilege to give this talk on anemia in front of a pioneer of public health nutrition like Dr. Bhatia, Dr. Mahapatra, Dr. Sonu Subba ma'am, Swayam madam. Thanks for inviting me to give this talk on anemia. And when Dr. Swayam contacted me and told me the topic was reducing anemia, so I was a bit skeptical because we have been working for anemia for last so many years, but have not been able to reduce anemia. But say my area of research, so I said I'll have to come and speak. But when I saw the first part of topic community participation, then I relaxed because that is even more difficult than reducing anemia, and that is next to impossible to achieve. And Dr. Bhatia mentioned one thing about mess food. So the crux, in my opinion, lies in lack of community participation in mess food. The students are not actively engaged in quality of food check. And in fact, just last week in AIIMS, there was an inspection by FSSAI of our mess, and out of 4 mess, 3 mess were closed. Fourth, they couldn't enter, so that's why that was not closed. So the quality of food, and Dr. Vinod Patro is there, he's my senior and teacher from AIIMS. So I was remembering the days when Sir was the president of RD at AIIMS. The quality of food used to be pathetic then also. So last 20 odd years, we have not been able to successfully improve. But that primarily because that is where this current topic comes into play. The community participation is one area that we have not been able to crack. And I personally feel that as a doctors, we are very bad at community and participation. We are very good individuals. And as Nani Palkiwala used to say, we are excellent solo players, but horrible team players. So that's where I think the challenge in this comes. Next slide, please. Next. So this will be the brief presentation. I'll try to touch upon theory of community participation bit, how this concept evolved, especially for undergraduates, it's of relevance. Poshan Abhiyan, that is a flagship program of Government of India and being championed by none other than our Honorable Prime Minister. And we have launched in 2021 the version 2 of Poshan Abhiyan. Anemia Mukt Bharat and the work we have been striving to do in the last few years, and community participation initiatives and the way forward. One thing I like to acknowledge, the name of the center that has invited us, Resource Center for Advancement on Public Health Nutrition. So it's one of its kind. I think no other medical institution, including AIIMS Delhi, has a structure like that. We have excellent public health groups, we have excellent nutrition group, but the amalgamation of these two disciplines, public health and nutrition, it's a standalone different academic discipline, I think, and the responsibility for this goes to Professor Bhatia, who imagined this 4-5 years back, and now Swayam ma'am is taking forward. So that is what the requirement of countries. On one hand, we say 50% of population are stunted, wasted, whatever parameter you say, and you do not have any public health nutrition group or academic discipline in the country. There's no course whatsoever available on public health nutrition. So there's a famous saying that the last thing a fish in a sea would notice is salty water. It is so ubiquitous. Nutrition is so much around us. If you see in peds OPD, nearly every patient would be malnourished, but you get used to that and you don't acknowledge those things. Next slide. This is Henry E. Segas, one of the champions of socialized medicine. So this is a comment on community participation by him. The people's health ought to be the concern of people themselves. They must struggle for it and plan for it. The war against disease and for health cannot be fought by physicians alone. It is a people's war in which the entire population must be mobilized permanently. So there are very provocative words in this. I deliberately put it up front. So that is, I'm trying to justify that statement over the 30 or 40 odd slides. And this is what has been the now basic ethos of Poshan Abhiyan also. We have a word that is called Jan Andolan, a mass mobilization or mass revolution as far as public and nutrition is concerned. And this was a term that was coined, I am told, by the Honorable Prime Minister himself. When National Nutrition Mission was presented to him, he said, this is the normal mumbo jumbo you doctors keep on saying. There's nothing new in this. So if you have to change the nutrition scenario that has not been addressed for last 70 odd years, you require people's participation, because that's where the problem lies. Next slide. And we belong to a culture where we tell a story if we have to make a point. So Dr. Vinod Patro, myself, we have been mentored by Professor Chandrakant S. Panda when AIMS group had done seminal work on universal salt addition. That is the only success story in public and nutrition in India, rather in health development field also. So currently 92% of our population consume iodized salt. So that had a basic or classic technological model. There was a AIMS research group led by Professor V. Ramalinga Swami from 1956. They came out with a solution that there's a problem, iodine deficiency disorder. They came out with a solution of universal salt iodization. They made a presentation to Indira Gandhi ji, who was the Prime Minister at that time. In 1983, they showed her a movie. She was convinced and she issued executive directive that from now onward, India should have mandatory salt iodization. So within a short period of 10 years, we were able to achieve a considerable success. But that is not the whole story. So you had health problem, you had a scientific solution, you developed an institutional structure for decision making, and policies were made. The program succeeded. Next. But in 1997, this ban on universal salt iodization was re-invoked. A 90-year-old Gandhian sat down in front of then Prime Minister's house, Vajpayee's house, and said ki salt is associated with freedom of India. How could you put a ban on salt? So these were the value system in the community. We forgot to talk to the population. We as a scientist, we said this is a problem, this is a solution, please go ahead and consume iodized salt. But we never consulted the population at large, and that came back to haunt us. So they convinced then Prime Minister, Swadeshi Jagran Morsha came into picture, Gandhians came into picture. Next slide. And this was a value system that they had. This is globalization, this is MNC sponsored program, though all the salt manufacturing companies were from India. Interest groups, loose versus packaged salt, small or big, and the ban was reversed. So the whole work of 30-40 years was undone within a short span of 5 to 6 months. Next slide. So that's where I think from the beginning itself, we have to be mindful of involving communities in any initiative that we want to take. Primary healthcare, as defined in Alma Ata, community participation is one of the key principles of primary healthcare. And there has been now shift from healthcare of people to healthcare by the people. What we mean by the people, it's slightly more than a traditionally understood meaning. So we need to focus on rights-based approach to health. Next slide. Next. So these are the various landmark initiatives that have happened. So after Seagrace in 1960s, there was very successful model of barefoot doctors in China, but that is only engagement in the delivery of services. That is not a true participation, community participation. That is only one component where we are involving. Alma Meta, all of us are aware of. BAMCO initiative and various subsequent initiatives do talk about community participation. Next slide, please. Village Health Guide was a very successful model that India had launched in 1977 based on Alma Ata, but because of various reasons it was discontinued. Trained dyes, I don't know how many of you have had experience to interact with these. So the whole program was based on trade burn attendance on trained dyes. But we as a scientist said, no, these are bad. So you go ahead with the skilled birth attendance or ANMs in this. Now again, there's a rethink in science. We are saying these might have been better. So we are again, Government of India recently launched a midwifery, national program on midwifery. Most of the Scandinavian countries, the most advanced nature with the lowest IMR and MMRs, do have these traditional birth attendants also as the primary service providers for maternity care. So as a scientist, we have to come out of that. We are always right. There might be another perspective to look at it. Accredited social health activists, ASHA scheme that has been very, very successful and has been transformative as far as public health scenario in country is concerned. Village Health and Sanitation Nutrition Committees is also one of the initiatives. Unfortunately, it has not taken up in the way it should have been. Next slide. So what are the domains of community participation? Need assessment, that sometimes we engage, we tend to ask the community what is their perspective, what do they want? Planning, mobilizing of resources, implementing, and monitoring and evaluation. So the same 5 phases can also be translated into inform, consult, involve, collaborate, and empower. But it is a very difficult paradigm to achieve because it puts us in a very uncomfortable position. From a powerful position, we become a service provider. If the community has a whole ownership, then we are in a very, and as doctors, we are very uncomfortable in doing that. But that is the way the community participation ideally has to be done. Next slide. These are the degrees of community participation as defined by World Health Organization. So various, so highest degree is when the most marginalized person. Community empowerment is not reaching out to the MLA and MP of that area and having him on board in your healthcare services. It has to be the most marginalized, the most weakest person in that community, and he has a role in deciding what services we are going to provide. Next slide. Poshan Abhiyan. So Poshan Abhiyan was launched in 2018 primarily with the aim of addressing the holistic nutrition, because we cut a very sorry figure when you go in the global fraternity and say we are a developed countries, but our all nutrition parameters are even worse than the sub-Saharan Africa. So we want to address this. We have been struggling to address this. There have been, unfortunately, not much improvement, though we are stagnated, and I presume even stagnation is not such a bad thing. At least we are not sliding back with whatever the changing scenarios are. Next slide. A Poshan Abhiyan 2 was launched in 2021, primarily realizing that we have not been able to achieve the target set out by Poshan Abhiyan 1. So the renewed focus is more on enabling environment, Jan Andolan community participation, and the initiatives like Poshan Maha, that September month, and Poshan Pakhwada in March are key to this Poshan Abhiyan. And India is one of the countries which contributes largest amount of money for food programs. We have 3 huge food programs where around $3 billion are spent by government of India. No other country, including China, the classical socialist societies, have such a heavily central funded programs. You have PDS, you have midday meal program, you have ICDS. So huge amount of money is going into these programs, but we are not still able to achieve the desirable results. Next slide. So Poshan Abhiyan Jan Andolan is one of the key pillars of this program. Next slide. Coming to Anemia Mukt Bharat, all of us understand anemia is a sign, a symptom, a disease or disorder. It's a multifactorial condition caused by various factors. It's a we say an iceberg phenomena because there are visible cases, but there are a large amount of people who may not have a manifestation of low hemoglobin count, but they still would have low iron reserves or various other micronutrient deficiencies. Next slide. This is the graph that represents the anemia prevalences in various age groups across the national surveys of last 20 odd years. So more or less we have remained at the same parameter. And I say anemia is more sensitive indicator as compared to your malnutrition, because it is one of the very tightly regulated, primarily iron is one of the most tightly regulated biological micronutrient in the body. It is the only micronutrient that doesn't have any known excretion mechanism. It is so valuable that whatever amount you consume, body conserves that. So we have not been able to manage much achievement. Primarily my perception is we have not sincerely tried. The amount of effort that are required to move the needle in case of anemia, that effort has not been made. IFA coverage, though we say everybody is consuming, it's less than 30%. That is the reported coverage. The actual consumption even may be less. And this is also what is prophylactic dose we are talking about. We are not talking about therapeutic anemia at all. So if you have 50% anemia and you are giving them prophylactic dose, so end of 1 year they would still be anemic. They would be at that same level. You don't expect a lowering of anemia if you're only giving prophylactic doses. It has to be a therapeutic dose. But that is not even an indicator in the program. We do not actually measure how many people do consume iron tablets twice a day. Next slide. Broadly, we know there are 3 domains of anemia. It's nutritional anemia, genetic or hereditary anemia, and infectious diseases which cause both acute as well as chronic condition which lead to anemia. Iron deficiency continues to be a single most important cause. One thing that I would like to highlight is we should be wary of coming with new solutions. If we are not able to address a problem, most often than not, we don't acknowledge our failure. Rather, we do away with the problem itself. So now there's a lot of discussion now that whatever anemia we have is not because of nutrition anemia, it is because of some other causes. Nutrition anemia continues to be the single most important cause of anemia. Various subgroup populations have documented that. So that has to be the message that we should be having. Next slide. In fact, WHO right now is thinking of lowering the cutoffs for hemoglobin. So that is the easiest way. If you lower the hemoglobin cutoff by around 0.5 gram or 1 gram, your anemia prevalences would decrease by 20-30% in a single go. But that is not the way. Ideally, I would want my wife, my children to have a hemoglobin of 14 or 15. Forget about 10 or 11. That is the cutoff that you prescribe. So optimally, sir mentioned about sports person. So there the requirement in myoglobin, besides hemoglobin, the other protein molecule, myoglobin is a critical component as far as athletes are concerned. So the requirements are much, much higher. I personally feel we are an iron deficient society. So that is where this comes into picture. It has got a lot of traction now because all nutrition targets, whether at global level or at national level, has anemia as a key indicator. So a lot of resources are being given, and I am hopeful that there have been some initial signs that the needle is moving now. And FHS5, those showed a increase in anemia, but the process indicators are changing. Your IFA coverage has increased by 15 percentage point in a short span of 4-5 years. That's a great achievement. Next slide. This is the Anemia Mukht Bharat, which was launched in 2018 on 14th April in Chhattisgarh, Bilaspur by Honorable Prime Minister with a very ambitious target of 3 percentage point reduction every year. So globally, no country anywhere in the world has managed a reduction of more than 1 percentage point per year. But we committed to this, knowing very well that if we strive for a higher level, at least we will move it by 1% or so. Next slide. This is a 6x6 strategy of AMB, which targets all 6 beneficiaries because it's based on the life cycle approach. That a mother who is anemic will have a child who is anemic, a child who is anemic will become an adolescent girl who is anemic and will end up with an anemic child subsequently. So that is the life cycle that we need to break. The 6th intervention, one of the intervention is community participation, social behavior change communication. And how critical simple messages, how they can deviate the whole program. We had a program by name of weekly iron folic acid, where supplementation is done in schools. Girls, initially only girls, now boys also were given. So UNICEF in one of its pamphlets somewhere mentioned that consuming this tablet will increase your weight. So scientifically that is a wrong statement, but that is not a concern. Once this pamphlet went to school, that is the age group when especially the girls don't want to gain weight. So the coverage of WIFs decrease in the schools that those pamphlets went. So the social behavior change communication has to be nuanced, and sometimes we may end up doing more harm. Next slide. So this is intensified year-round behavior change communication campaign. So this is what the one I was saying. Solid body, go back. Solid body and smart mind. So this solid body in different cultures might be interpreted differently. So that's where the role of community participation, community messaging comes into play. Next slide. NCRA was established in 2018 in AIMS, primarily as a technical support unit to provide inputs to Government of India for this program, incorporating scientific policy and very importantly community perspective in policy and programmatic. You may have a solution that will be scientifically viable, but the community may not accept those solutions. Next slide. The objectives of NCRA: technical inputs, research needs, program implementation monitoring, acting as a reference laboratory, facilitate capacity building, mentor and support regional centers. Next slide. Coming to the community participation, I'll just highlight few initiatives that we have undertaken in NCRA at AIMS. And this was a revolutionary learning for me also. We started out with these camp under guidance from UNICEF. Sir was at that time, we had invited sir also for this was in 2018, Poshan 2018, when this program was launched. So at a very short notice, we undertook it. We never realized such a simple thing would transform into such a transformative initiative 4-5 years down the line. So what we said was test, treat and talk. Within the same station, you test the individual for anemia, treat them if they are anemic. If they are not, then give them prophylactic dose and talk. Give them dietary advices or whatever behavior modification are required. And one of the things I have learned is still now 40, 50 years, we were basically diagnosing anemia using clinical examination. So that is useless for mild and moderate anemia. It is as good as flipping a coin. So simple technological innovation of digital hemoglobinometer, which costs somewhere around 10 rupees per test, has transformed the landscape of anemia. Now woman actually knows her hemoglobin values and she comes for a ANC checkup. She has a hemoglobin of 9.8. You give her IFA for 1 month. She comes next time it's 10.5 and she's happy. So that objectivization of the results is there. So that has led to this transformation in this program. And I'm happy that there are a lot of young students here. So we are struggling because there is a lot of innovation that is required. Unfortunately, nothing has happened in anemia research in last 20, 30 years. We are trying to implement what was the learning 20, 30 years back. Dr. S.K. Sood was at AIMS in pathology in 1970s. Whatever basic research he did in 70s, we are still implementing that. There is a need for having a non-invasive digital hemoglobinometer. You can test individual's hemoglobin without giving it a prick. In today's day and time when we can send a spaceship to Mars, I fail to understand why we cannot have a technology that can tell us hemoglobin without pricking or giving a blood. Because we need to prick. I run a secondary care hospital where the ANC is 500 to 600. So there you have to do so many hemoglobin tests in individuals. So biomedical waste generation, the time that goes into that. So these small innovations, we are in dialogue with teams from IIT Delhi. I have interacted with IIT Bombay also. We talk to global people also. But unfortunately, none of the IITians these days are into engineering. All of them are entrepreneurs. So the basic engineering skills are missing. And I am worried, sir, frankly, for MBBS also. I think we are also giving this same track. Our MBBS students also now are AIMS Delhi. I don't know about this institution. All of them are already starting startups, first year onwards. So they're not reading medicine, they're into some other. So a core skill. And these kind of innovation would come when a medical doctor interacts with the engineer and come out with solution. I think we need these kind of solution. That's why we have not been able, because anemia is nobody's problem globally. West has 10% anemia. It is a 50%, 60% anemia for us. No new molecule for iron has come out in last 20, 30 years. Whatever innovation have come is primarily for chronic kidney disease, CKD patients. So those formulation we try to adopt for public health, anemia, nutrition elevation. So these innovations are required. Next slide. So these anemia camps were subsequently held and now are part of the program. Any event that is held, these T3 anemia camps are held. And last year, I think 13 crore individuals were screened all over India through these camps. Next slide. Some of the states on their own have gone ahead and they are even more adventurous than Government of India. Have decided to screen whole of their state during these weeks. Haryana recently launched a program. They said, why twice a year? We'll do it 4 times a year. And they do have resources. Some of the states do not depend upon central resources. Odisha is one example. They have a lot of innovation. Odisha was already doing a lot of nutrition activities before Poshan Abhiyan, and they're more or less similar. Next slide. So this was we took an opportunity. There was an initiative where the district collector is required to camp in a night camp as a mandate of government. So we caught hold of him and tested him in that camp. So the whole village was mobilized and they got themselves set. So these are the, you have to think on your feet sometime and take these initiatives. Next slide. Himachal Pradesh is also undertaking a lot of new initiatives. They're talking about primarily focus, as Dr. Vinod Paul is directly involved in this, focus more on pediatric anemia because that is another area where we have not been able to make much dent. So they want to screen all children from 1 to 10 years of age. Next slide. Next. And looking at early identification treatment of anemia, and particularly new innovations like treating giving iron to low birth weight babies. Traditional knowledge is we need to supplement iron after 6 months of age because that is the time maternal iron through breast milk is sufficient for the child. But low birth weight baby might require higher amount of iron. So there's a case for supplementation that, and this is being tried in program mode in Himachal Pradesh. Next slide. Capacity building for anemia. One of the mandate of AIMS is to reach out to other AIMS, and I'm happy. But what I perceive is these newer AIMS are more like extended family for us, and we are grateful that a lot of initiatives are being undertaken. Some of them are doing even better than what main AIMS is doing. So yours is an example as far as public health nutrition is concerned. So we have been training, and I think more than 200 master trainers have been trained on this. Next slide. So several of these meetings are held, and these are intensive activities because if you imagine the amount of workforce that needs to be trained, it cannot be done by one institution. Even 25 AIMS are less, because every ASHA, every ANM, the whole of country has to be trained for one simple method, digital hemoglobinometer. But the public health program requirements become humongous. So that's where the role of community participation, engagement with more and more people comes into picture. Next slide. Next slide. So we have been in dialogue with Pediatric Association, FOXY, on domain-specific areas of pediatric anemia, maternal anemia, as well as adolescent anemia. Next slide. One of the new challenge that has come up, and that's where I think the community participation perspective comes. Government of India has launched a very ambitious program of fortifying all rice consumed in India that is supplied by public distribution system. So around 1/3 of your population would be covered by fortified rice within 3 years. And we forgot to engage with the community while rolling out this program. So all of you, I'm not a rice eater per se, occasionally I eat rice. So rice fortification is a very challenging concept, because people don't consume nutrition, they consume food. And if you interfere with their food, it becomes very difficult. So a lot of opposition is there to rice fortification now. Because the fortified rice looks slightly different as compared to the normal rice. So in fact, I have to go to Jamshedpur tomorrow for a meeting in one of the district where a lot of activists are up in arms against rice fortification initiative. Next slide. So what is the way forward? We have to understand anemia is a multifactorial disease, and you have nutrition-specific, nutrition-sensitive implementation, food-based approach. Medical care is only one small component of it. Public health measures, and all of these require a massive amount of SBCC. One of the first exercises I give any postgraduate or undergraduate student who wants to work with me in anemia is ask him to consume IFA tablet for 180 days and then come back to me. Before you start criticizing patient, that's difficult to consume. Within 2 weeks, your stool ka color would change. 30% of individual, it does change. You will have constipation. So those, you have to understand some behavior change. Consuming pill day in and day out, it's an alien behavior. Humans are not comfortable consuming a tablet, especially for a condition or a disease they don't even perceive they have. So these are the behavior modification and does require a lot of reinforcement. Next slide. Evidence to decision making framework. All of us are very fond of evidence-based medicine. But WHO has recently come out with this 7-pronged step, and they said science is only one part of it. You need to have benefits, balance of benefits and harm. Values and preferences of community are very, very important. Acceptability of intervention. Resource implication. I might have a very successful intervention available, but I cannot afford it. FCM improves your hemoglobin, and even in a severely anemic, by 3 to 4 grams within a span of 2 weeks. But it costs 2,000 rupees. If you start giving it to all moderate anemia, 30% of the individual in my OPD, ANC OPD are moderately anemic. So the whole budget of Ballabgarh Center would go in providing this one intervention, the rural center that we are running. So that may not be resource sensitive intervention. Equity and human rights. People who require the most, they are the ones who will never be reached. We say less than 5 grams. There's a classic example in anemia Mugbhat. We say less than 5, it has to be blood transfusion. But it's prohibited. You cannot give them anything else. But those of us who work in the community, even at 2 or 3 hemoglobin, the women will not get blood. Nobody will donate it to the women in that family. They will donate it to the men in the family. So that is not the intervention that is available to them. So you have to think of alternate. Next slide. We are talking a lot of about now quality in nutrition initiatives. Though we have a massive programs, the quality of food or quality of services being given in these initiatives are not up to the mark. So there's an adage in public health that only if the most influential part of your community accesses your services, then you will be able to reach to justice. If only the poor are coming to your center, if the AIMS hospital becomes a center only for the lower one-third of the society, then over the years the services will deteriorate. It's only when the richest person in Odisha or richest person in India aspires to get treated in AIMS, because that should be the quality benchmark, then only you will can ensure that your services would be optimal. Next slide. Social media is a big challenge now. Everything you do, even if you do it, not do it, at least it should be on the Twitter. So we have been striving to do it, and it does have a lot of positive fallback. We didn't get the traction that much but once Odisha topped and Naveen Patnaik ji tweeted his photograph with anemia Mukh Bharat that we are doing good, suddenly the things became so much easier. Till that time, the government of Odisha was not even acknowledging AMB as a program, because it said we already have a program running, AMB is something different. But once the ranking was given and they saw we are number 1 or number 2, then they said, okay, now we'll have this program. So the social media also had a lot of benefits. Next slide. We talk about partnerships. So on our own, we cannot do ourselves. We sometimes assume a lot of responsibility as a doctors, that we will do everything, we'll make everybody healthy, and this. We are just a small player in the larger universe of things. You have government agencies, national and state, Panchayati Raj institution. Private sector increasingly has so much role to play. Academy and universities, civil societies, they do have their role because they are our sounding board. Sometimes in overzealousness I might do, and if I'm working anemia, I only see anemia, I don't see anything else. I still remember a long time back, in one of the meetings, one person said, if you have to eradicate rabies. So he was a rabies person. He said, it's simple, you vaccinate 90% of dogs in India and rabies would be eradicated. And none of us realized that there was a folly in that. There was a illiterate MLA in that meeting. He said, Dr. Saab, you know how many of Indian children are vaccinated? You're talking about 90% vaccination coverage in dogs. So we sometimes lose perspective if we champion one particular cause. So civil society does have its role to play. Non-governmental organization, international, bilateral, multilateral agencies, they bring in global learning, global resources. I'm not that much keen on their resources. We have sufficient resources of our own, but you do need some global level academic and research rigor, media and quasi-judicial bodies. Next slide. So take-home messages. People have central role in health. Community participation is key pillar of health. Primary healthcare in particular is not possible without community participation. You may be able to run an institution like AIMS or a secondary care hospital. But when it comes to primary healthcare, if you do not have a buy-in from community, you will not be able to take the first step. Belief in value system of community and evidence-based decision making is critical to success. Health is a fundamental right. Public good and a right-based approach. Increasingly now that understanding is coming. It's not something that we are giving to community. It is something that they own. We are just a provider of services that they anyway deserve, or they own that. Anemia is a significant public health problem. We have nutrition-sensitive and nutrition-specific approaches to nutrition. And social behavior change, communication is the key, because you require that intervention day in and day out. It's not that I become non-anemic today and rest of the life I can relax. It is a behavior, lifestyle modification. T3 camps, states, district level campaigns, social media, rice fortification, the newer challenge. It could be a transformative intervention, but it is facing so much challenge because the whole environment has to be changed. It requires so much effort. And lastly, the community of community medicine departments of AIMS, I think we are building step, a lot of exchanges are happening, and we are grateful to a lot of people that Dr. Vikas Bhatia is fond of calling. We have reached century in terms of that group you have in CFF, so 100 members and so community medicine faculty members. So that group is increasing. I think we need more and more these kind of institutions and people to make this public and nutrition a success. Next slide. Next. Thank you so much.